Ropivacaine is almost very much similar to bupivacaine, but only it has a propyl group on the piperidine nitrogen atom as compared to bupivacaine, which has a butyl group. The short length of the carbon side chain on the tertiary nitrogen atom makes ropivacaine a less lipid soluble than bupivacaine, and it is also influences the potency of ropivacaine. So because ropivacaine is less lipid soluble, there are very less chances of CNS and CVS toxicity of this drug. So as you can see, it's turned upside down. Okay, anyways, just to recollect, because of the variability in the lipid solubility of ropivacaine and bupivacaine, ropivacaine is less likely to cause the CVS toxicity as compared to bupivacaine, because it has less affinity for the sodium potassium channels of the cardiovascular system. Next. Ropivacaine, being less lipophilic, ropivacaine penetrates the less into large myelinated motor fibers. Therefore, it has a selective action on the pain transmitting A delta and C nerves rather than A beta fibers, which are involved in motor function. And because of this relative more affection on the sensory nerves, even it has got a large sensory motor differentiation in its blockade. The patient might have good sensory block but very less motor block, and that is the reason why using ropivacaine heavy will cause less of hypotension as compared to bupivacaine in the clinical practice. Apart from being less lipophilic as compared to bupivacaine, ropivacaine has different affinity for different ion channels of sodium, potassium and calcium, and this results in the significant reduction in the cardiac and CNS toxicity of S enantiomers. It has more sensory blockade as against the motor block, so it gives a very good differential block. So patient, it is basically, it can be very well compared with even levobupivacaine. It causes very good sensory block, but the motor block, it might not lead to that much. Ropivacaine potency. According to the minimum local anesthetic concentration studies, it has been observed that ropivacaine has similar potency to bupivacaine at higher doses. It is less potent than bupivacaine at lower doses. It is 40% less potent than bupivacaine, but at equipotent when used in the ratio of 1.5:1. Ropivacaine initially, what was launched, heavy ropivacaine was not launched in India at least. It is only Neon that it has launched the heavy molecule. Otherwise, the initial studies what were being done, they used to add 5% dextrose to make the plain ropivacaine, which was available in 0.5% and 0.75% in the vials. Ampule form was not, the heavy form was not available. So studies were initially done by adding 5% dextrose to the ropivacaine which was plain, which was iso. Then it was made heavy and then it was compared with bupivacaine. Now we have easily available ropivacaine heavy. So the Ropivacaine era, Ropivacaine was commercially available for clinical use in 1996, but in India it was launched almost after a decade. In 2009, Neon introduced Ropivacaine, that is Ropin, in isobaric form with different concentrations. They have three concentrations, 2%, 0.5%, 0.75%. However, with the constraint of caudal and kephalate spread, the use of plain ropivacaine for spinal block was limited. So why basically heavy? August Bayer, who is the pioneer in spinal anesthesia and in IV regional anesthesia, that's why we say it as Bayer's block. August Bayer himself observed the great inter-patient variability in spread of the plain LA solutions. Plain LA solutions have more variability and lesser predictability, and gravity and baricity have a great influence in the spread of LA in the CSF space. So he also promoted the use of heavy local anesthetics while giving spinal anesthesia. So this is basically the contours what we see when a patient is lying down, and that is the reason why we are observing even when we give spinal anesthesia in our L2, L3 or L3, L4 conventionally, the drug usually accumulates in your sacral space and the thoracic spine. So that is the reason why we may get a prolonged higher T4 level block in case of when we are using heavy local anesthetic agents. Next please. So the concept of baricity. Baricity is the relationship of density of the LA solution to the density of the CSF fluid. If the LA solution is less dense than CSF, it is hypobaric. And in case of hypobaric, if we are using, it is very difficult to predict the level of action. If it is equal to the CSF, it is isobaric. And if it is more dense than CSF, we say it is a hyperbaric, and that's why it sinks wherever the gravity is there. And that is the reason why we are usually tilting the table when we use a hyperbaric solution. As a concept, baricity refers only to the spinal anesthesia and not to the epidural anesthesia, because in epidural there is no fluid. So what is the basic difference when we are using a hyperbaric solution or one is using a plain LA? Plain LA are marginally hypobaric, whereas addition of glucose, they increase its density. Glucose-free solutions produce unpredictable spread of LA in the CSF, but whereas a hyperbaric LA results in more even distribution of the local anesthetic agents. Even hyperbaric LAs are more rapid onset with less variation and a more predictable sensory and motor block, whereas in case of glucose-free solutions, that is hypobaric solutions, they result in inadequate distribution of block. Gravity does not encourage the spread in case of supine position one is using isobaric or hypobaric, as we have seen today morning also. Paliwal sir gave spinal Ropivacaine in lateral position, whereas the operating side was up only. So gravity does not play a role, whereas gravity helps the spread of drug down the curve of the lumbar spine. Hyperbaric solutions are more predictable with greater spread in the direction of gravity and less interpatient variability. So motivated by these findings about the baricity of drug and its effect on spinal injections, many studies comparing hyperbaric Ropivacaine with hyperbaric Ropivacaine were done and published in the literature. So considering the essentiality of hyperbaric Ropivacaine, in India, NEON has initiated a phase 3 multi-center randomized double-blind parallel group comparative clinical study to evaluate the efficacy and safety of hyperbaric Ropivacaine hydrochloride, which is 0.75% and is equipotent to 0.5% bupivacaine, compared to the hyperbaric bupivacaine hydrochloride 0.5% given in spinal root. The efficacy of study drug was assessed by following endpoints. Because conventionally all over India, everywhere heavy hyperbaric bupivacaine was used. So as compared to it, Ropivacaine being a less cardiovascular toxic, causing less of hypotension, it has to undergo all the clinical trials. Even today, the phase 4 trial is still yet to come. The efficacy of Ropivacaine heavy in cesarean sections have still not been proved. But many people are using. I know Paliwal sir is also using, and I think he is using with very good effect. So there is definitely, we have a good strong support that one should use Ropivacaine heavy. So these are the studies and the results which you can see on the screen. Basically, both are absolutely comparable and there is no much difference in it. The time required to achieve sensory block up to T10 is in Ropivacaine and Bupivacaine is also comparable. Almost there is no difference. The time required to achieve the maximum level is also hardly a difference of 2 minutes. The time required for onset of motor block is, in case of Ropivacaine, it is more than what you can see in Bupivacaine. And the time required for complete recovery of motor block again is almost similar, hardly a difference of 3 to 4 minutes. The total duration of sensory block from time of injection to first demand for analgesia is also comparable. So definitely these two drugs, just Ropivacaine being a little less potent than Bupivacaine, they both are actually comparable. Ropivacaine study results, in conclusion, all the efficacy parameters were statistically comparable in both the groups. All the amides were whatever the anaphylactic reactions were mild in nature and they did not warrant any active management, suggestive of safe profile of Ropivacaine hydrochloride 7.5 mg in dextrose 80 mg per ml injection. Thus, in this phase 3 clinical trial, it was proved that 0.75% hyperbaric Ropivacaine has shown comparable efficacy and better safety profile in comparison with 0.5% of hyperbaric Bupivacaine when used by spinal root. So this also is a graph which is depicting whatever the results are there as in case of onset of sensory block up to T10, then onset of motor block, even peak level of sensory block one can see. This is in case of Ropivacaine and this 12.9 is case of Bupivacaine. So almost all the figures are definitely comparable. So in summary, when we are assessing his hemodynamic status, in case of Bupivacaine, one has usually seen a patient will have fall of the blood pressure, there might be any changes in the heart rate. So tachycardia, in Ropivacaine, it is 2.75% and instances in Bupivacaine was quite high, 7.45%. The incidences of bradycardia was hardly negligible in case of Ropivacaine, it is 1.83%, whereas in Bupivacaine it is 1.85%. Pyrexia has been noted in 1.92% in case of Ropivacaine. And whereas vascular disorders, that means hypotension was noticed in 4.63%, whereas in case of Ropivacaine it was 2.75%. So one can actually expect a quite hemodynamically stable patient in case of Ropivacaine heavy as compared to Bupivacaine. So, to all the delegates, I hereby say that Ropivacaine heavy I have been using even in my clinical practice, and it has been a really good drug with good effect, good sensory effect, with not much of hemodynamic instability. And in case of cesarean sections especially, it is also a promising drug. The trials are going on. But I think one can get a definitely good result with Ropivacaine heavy, because especially in cesarean sections, one can experience the sudden drop in the blood pressure, much sustained drop, sudden changes in the heart rate. They also occur with Bupivacaine. But now they are going to compare it with Ropivacaine heavy. So I think there will be a good promising result about it. So that's it. So Neon brings 0.75% hyperbaric. Neon is the only company which has launched Ropivacaine heavy in India. So we look forward to your valuable feedback for that. Thank you.
You can jolly well use Ropivacaine heavy instead of Bupivacaine as well. they are almost the sensory effect, in motor block, in duration of application, everything is comparable with the both the drugs. And on the contrary, it is more safe. Hemodynamic effects are less pronounced with Ropivacaine heavy than Ropivacaine, then definitely one can go for it as per Dr. Radha said.
Thank you very much. Thank you.
Dr.Naresh sir, for the second lecture.
With hypobaric drugs, you can have a unilateral spinal, and there is a new term, posterior spinal hemianesthesia, which can be done with hypobaric drugs only. If you give hypobaric drugs in prone position, you will have a posterior spinal hemianesthesia. This is a new term, which can be, done with the patient in prone position only and using hypobaric drugs only. And other thing is, you can do a jackknife position, then give prone position spinals and continuous spinal anesthesia. Now coming to spinal anesthesia with hypobaric drugs, the average density of CSF is 1.0069, and to make the drug hypobaric, the density should be precisely below 1. So we need to add some distilled water. It is basically used for anorectal surgeries in jackknife positions, but it is also useful for unilateral hemianesthesia for lower limb and even superficial thoraco-abdominal surgeries. I have done simple mastectomy even under this hypobaric drug, unilateral anesthesia, but the effect lasts very short-lived and there is some sparing of motor power. So it is useful for only high-risk cases of short duration. As I already told you, posterior spinal hemianesthesia is another possibility. You need to prepare hypobaric drugs by mixing sterile distilled water. It's also useful for lower limb surgeries, as we have already demonstrated these things, so I won't go in detail. There are some advantages. There are very negligible hemodynamic fluctuations, so can be used with the high-risk cases. Low doses of the drugs used lead to preferential sensory blocks, as we have seen already. Disadvantages are the hypobaric drugs need to be prepared, so there are always chances of contamination. And other thing is the hypobaric drugs, as the difference between the density of CSF and hypobaric drugs is not much, they are less predictable, as also Dr. Radha has already told you. The hyperbaric drugs are more predictable. So many people, they don't try to use these hypobaric drugs, but if they are used according to situations, they are very good drugs. There is less muscle relaxation and need for sedative is more often. Another method is you can just warm the hypobaric drug to 37 degrees, can give you a hypobaric result. This was a surgery, lateral sphincterotomy, which was supposed to be done under jackknife position, but in time the surgeon said he will do it in lithotomy position. So we just continued with our plan of hypobaric drug, 1 ml of levoanamine and 1 ml of distilled water. And the patient was given lithotomy position. You can see he had just adequate effect at the sacral roots. You can see his power immediately after shifting, and complete motor power. This was another case, it was done by our lecturer, assistant professor. Debridement, like we did today, half ml of levoanamine and half ml of distilled water. This patient was done in supine position after keeping the patient for 10 to 15 minutes in lateral position. You can see here, there is some motor loss in the right leg, but you can hear the sound of our. This is prone position spinal. I have given price. Now the another topic, continuous spinal anesthesia. Continuous spinal anesthesia is producing and maintaining spinal anesthesia. Small doses of ARA injected intermittently through subarachnoid space via an indwelling catheter. Can be a planned technique or it can be modified after accidental dural puncture. It's very useful in several key clinical situations. It has more rapid onset, more pronounced sensory motor blockade, fewer hemodynamic alterations and side effects. By reduction and fractionation of the induction dose of LA through the catheter, there is slower onset of capillary block that allows cardiovascular system to adapt more easily. And the indications for this continuous spinal anesthesia is also given in Miller's. They have given indications of severe aortic stenosis, DPCM. These all cases can be done under continuous spinal anesthesia. Now, when to consider CSA? It can be intentional or unintentional. Unintentionally, when you have an accidental dural puncture. Intentionally, it can be thought of in cases where there is a difficult intubation or long duration surgery, obese parturients or patients with obesity for long duration surgeries, difficult airways, prolonged surgeries, and patients who have had previous spinal surgeries or deformities in the spine, where the epidural may not act properly. Equipments, micro-catheters were previously banned due to Cauda syndrome, but now they are available again. Equipments can be either macro-catheters like we use today, epidural catheters, or they can be micro-catheters. Even pediatric epidural catheters can be used. Specially designed spinal micro-catheters. Catheter over the needle side. This is spinal cats. The kit consists of 22 gauge catheter mounted over 27 gauge Quincke needle, or 24 gauge catheter over 29 gauge Quincke needle. The Quincke needle has a fluid exit side hole and also a braided wire, and it also contains the epidural needle. The technique is same as we do under combined spinal epidural. You have to reach the epidural space first with the epidural needle and then puncture the dura with the spinal needle. And once the free flow of CSF is seen, remove the braided wire, spinal needle, and then the epidural needle, and connect the catheter to the filter. With catheter over the needle set, there are less chances of PDPH, as the hole created by needle is sealed by catheter. Then catheter through needle set, there are varying sizes of 25 to 32 gauge with stellate introducer, but these micro-catheters are difficult to insert. They can kink easily and it's difficult to aspirate CSF. Insertion of catheters more than 3 centimeters in subarachnoid space increases the chance of catheter being caudally directed. And if the catheter is caudally directed, you have high chances of Cauda syndrome. And curled up catheters may snare the nerve roots while pulling. Epidural catheters like what we use today, so I will not go in details about this. This is a video which I have already demonstrated today, so I will skip this video. This is gravity test to confirm the free flow of CSF, I have already demonstrated. Then some tips for continuous spinal. Be gentle advancing catheter into subarachnoid space. Gravity test to confirm the tip. Then isobaric Ropivacaine is better than hyperbaric drug. And make sure everyone knows this is a spinal catheter. You have to label it. Otherwise, anyone can put a epidural dose through the spinal catheter and patient can go in total spinal. You have to label it strictly. This is another set which is available, Spinocat. This is a 21 gauge sprout needle. I'll just show the video. This is Spinocat. Once the sprout needle is introduced, the guide wire and slit, just like we do it for our CVP line, it is introduced. Once the catheter is in, remove the guide wire and the slit introducer. These are not available here, and these are costly, around 5 to 7 K. Another technique is same as we have done. I will skip it. Drug doses according to need of the surgery. Catheter dead space can be 0.2 to 1 ml. As I have demonstrated, the dead space of our epidural catheter was 1 ml. Usually 0.5 to 1 ml of the drug as the initial bolus. Then after testing the level, you can give increments of 0.5 ml. According to situation, you can use any drug, hyperbaric, isobaric, hypobaric. Flushing the catheter after each bolus with normal saline is recommended. Some people do it, some people don't do it. Just keep in mind that there is a dead space, and before pushing the next dose, you have to keep in mind that there is a drug inside the catheter which was not flushed. Adjuvants, any one of the adjuvants can be used. Flexible soft catheter should be preferred. Transient paresthesia is common during insertion. Not more than 2 to 3 centimeters should be inserted. Never withdraw the catheter back into the needle shaft. If you want to withdraw it, withdraw the needle along with the catheter. Otherwise, the catheter may shear off. And the high risk of infection, so keeping the catheter in place for more than 24 hours is not recommended. And to reduce the PDPH, keeping the catheter in place for at least 24 hours is advisable. Strict labeling, already told you the advantages. Now something about the continuous spinal labor analgesia. Someone was asking me this question during lunchtime. So there are appropriate candidates for this. So I have not used this for continuous spinal labor analgesia. But there are some appropriate candidates where it can be thought of, like parturients with prior back surgery, difficult placement of epidural or poor landmarks, in morbidly obese parturients, where the risk of PDPH is very less, you can think of this, and parturients with cardiac diseases, and in cases where there is a high probability of cesarean section, and patients with potentially difficult diabetes. The advantages are excellent analgesia, no motor block, easy to determine proper placement, and it also provides a route for other medications. We know CSA is a reliable, flexible technique with improved patient satisfaction, but what is the risk of PDPH? Will this make her headache worse? Could it actually improve the situation? You know, once you do accidental dural puncture, then don't panic. Your initial reflex is to pull the 2 needle out, but don't do it. The die is already cast, the damage is already done. You just go ahead with it, just roll with it. It's an opportunity to give this patient a great anesthetic. Actually, the PDPH is lot lower when you put the catheter in for a continuous spinal. There is decreased need for this blood patch, epidural blood patch by 61%. It is decreased by almost 96% when the catheter is left in situ for 24 hours. The risk of PDPH is lower when you put the catheter in for a continuous spinal. And in the morbidly obese parturients, it is even less likely to develop a headache. The PDPH is decreased by almost 46% with BMI more than 30. The technique is for continuous infusion. You can have 0.1% Ropivacaine or 0.0625%, 0.1% Ropivacaine with 2 micrograms per ml of fentanyl at the rate of 2 ml per hour. This is for continuous infusion. And provider patient control top-ups, you can have 1 to 2 ml every 15 minutes and maximum top-ups of 3 per hour. Intermittent boluses, you can give 2 ml per hour with the same dose. And for cesarean delivery, initial dose of 5 to 7.5 milligrams or 0.5% isobaric, Ropivacaine, whatever drug you want to use. And titrate the dose for desired level, 2.5 milligram incremental boluses every 3 to 5 minutes. And you have to remember the dead space of the catheter. Risk and disadvantages. Risk of CSA for all practical purposes are similar to those with any other neuraxial block. Disadvantages: risk of infection, PDPH cannot be used for more than 24 hours, post of analgesia, but still CSA is a useful technique to have in every anesthesiologist's armamentarium. And thank you once again for patiently listening. Thank you.
For labor analgesia, you said that there are less incidence of PDPH.
Yes.
So may I know what is the reason?
Reason
In morbidly obese patient,
there is compression of the thecal space and all it might be the reason.
means leak will be less of the
It is
leak will
quoted to
be
be less in obese parturients. Otherwise, the incidence of PDPH is very high in young female patients. Otherwise, also, and especially in parturients. And they have quoted the incidence to be very low. Maybe probably because of the compression of the thecal space, because of fat and weight.
Yes, they rather advocate this continuous spinal in morbid patient.
Yeah.
Morbidly obese patient, they rather advise for continuous spinal injection.
Thank you very much, Dr. Paliwal sir. I request Dr. Pandey sir to open up appreciation to Paliwal sir.
Academic fees. I would like to welcome Mr. Rajesh Shah sir for the panel discussion as a panelist. Dr. Rajesh Shah sir, who is the General Manager and Head of Anesthesia and Critical Care, Bal Sangha Pediatric Hospital. Dr. Radha Saodekar madam, she is the Associate Professor at DRPdmmc Medical College. Dr. Jayesh Singh sir, he is also an Associate Professor at DRPdmmc Medical College. He is also an eminent speaker and special interest in pediatric anesthesia. Dr.Naresh Paliwal sir, hopefully we don't need any introduction to the Paliwal sir. Now time to begin a panel discussion.
We have since morning thoroughly witnessed all the cases and regional anesthesia in and out, I think. Everybody must be satisfied with all this, whatever you have witnessed. So the discussion is basically for, you might have seen all those some new drugs being used like Ropivacaine, and all those things, and also those methods which conventionally you might not have done anywhere. So to start with, actually this will be a free question answer session because after all these lectures we never had any question answers in detail. So as regards the hypobaric solution, what sir has used, I think for debridement sir you have used, you made it hypobaric, right? But it is said that the level and predictability is not so definite as in case of hyperbaric solution. So I just want to know how do you really manage the level, because see we all are accustomed to using hyperbaric drugs.
Hello.
At least I myself, and immediately searching for making the patient head low or head high. That is my usual reflex once I give spinal. So that's what I really wanted to know.
There are few changes I have made actually. The described technique is actually take 1.5 ml of Ropivacaine, add 3.5 ml of distilled water, make it a 0.15% solution, and then inject some 2-3 ml. So the volume becomes more. So what I did is I have changed things. I took just 0.5 ml of the distilled water and 0.5 ml of the drug and made it 0.5%. So because the volume used was very low, so it became very predictable. This is a change which I have made from my side. By doing repeated cases, I have changed these things. Initially we used some 1 ml and 1 ml distilled water. So instead of going according to book, I changed it and it is quite satisfactory. The levels were not unpredictable. The levels were quite predictable. And they were limited just below L1 level. Otherwise what happens when you use a 3 ml of 0.15% solution or 4 ml, the level goes up to T1, T2 levels, which is not required. And the concentration gets very low, patient gets discomfort during some deeper dissections. So I changed it to 50-50, not according to book.
Just an academic question, like what you are telling, hypobaric drug, if you give more volume,
So if it is an hypobaric, can we do the head low and can control the level simultaneously?
Even if you do a head low, because the volume is
Yes.
too much, and like I said, if you make a 0.15% solution, you need to inject at least 4 to 5 milligram of the drug. That means 1.5 milligram per ml. That is, you need to inject 3 ml of drug for 4.5 milligram.
No.
Because the volume is more, the spread is unpredictable.
Yes, not to agree, but what I mean to say, if you want to do a like HRA with the hypobaric, will it be possible?
Which surgery?
HRA, heavy replacement or surplus?
Yeah, it can be done, but for that only sensory component will be involved. Like I
So
said, because the drug use is very less, it is only for superficial surgeries.
So there will be
For
problem
local
with the-
surgeries, you need to give higher doses. You can use 1 ml of isobaric and 1 ml of distilled water and keep the patient head low. That will give you both.
But then relaxation part will be
Relaxation will be good because you are using total mass of drug is 5 milligrams.
Yes.
That will be not as good as with hyperbaric drug, but it will be better than the other concentrated. So according to the situation, you can change your this thing. The drugs which are available, they are on the verge of being hypobaric, and even little addition of distilled water makes them more hypobaric. So you can change your technique according to your situation.
Do you have questions?
How long the action of this hypobaric will persist?
This is just around an hour, 50 to 60 minutes.
Short case.
Yeah, this is for short cases only. This is mostly used for daycare orthoscopic surgeries. If you search for the reports of hypobaric drugs, it is used for knee joint orthoscopic surgeries, daycare orthoscopy. And for that also the surgeon needs to be accustomed to the less relaxation. Relaxation is less. Surgeon should be accustomed to this. Mostly used for this orthoscopy surgeries, apart from the anorectal surgeries.
Skin grafting and that can we go for?
Yeah, you can do it. Any type of superficial surgery where relaxation is not required, any type of comorbidity, because the hemodynamic fluctuation is very less. Drug use is very minimal.
So is the volume of the hypobaric LS is constant in both thoracic segmental spinal and abdominal segmental spinal?
I didn't get you.
So is the volume of the drug which we inject into the CSF?
Generally, for segmental spinal, we use isobaric or hyperbaric drugs.
Isobaric.
Isobaric and hyperbaric, the dose is almost same. Dose and the site of injection.